the data on the effectiveness of treatment of trigger points, manual treatment, dry needling, a cold laser, the literature is growing in credible studies, not poor studies, randomized controlled studies with sham needling, randomized controlled studies with sham cold laser.
Yes.
The evidence is mounting about the effectiveness of treating trigger points.
You've just written a paper recently about trigger points yourself, haven't you?
It's been out in the world for less than 3 weeks.
Right. Does that reveal something that we ought to know about?
I would hope. No, it is a new hypothesis of trigger points. It's based on on an old idea, 150 years old now, of maintaining homeostasis. That is, that biological systems are maintained within limits. And if you wish, there's a teleological purpose in the way the body works to prevent injury. You go outside of the parameters and you expose that tissue to damage or to cell death. And in muscle, there are systems that are protective. There are feedback mechanisms. So the idea of the paper is that there is a failure of feedback mechanisms that are normally built in to protect the muscle. And one whole set is the sympathetic nervous system, and the other that I specified in the paper has to do with the mechanisms that control the amount of calcium that goes into muscle cells, because what goes in has to go out. That's energy requiring. If it accumulates too much, the cell gets damaged. And I think that's what happens in trigger points. So there are ion channels through which calcium flows, through which potassium and sodium chloride flow. And so I specified 2 particular ion channels that do this. One of them, which was intriguing to me in the response, is the ryanodine receptor that is known best as when it fails as a cause of something called malignant hyperthermia, so that there's a set of people who have a mutation in the ryanodine channels so that it's leaky, and you get too much calcium in, and you expose these people function well until they are exposed to some substance. What was well known for a long time was a subset of anesthetics. Halothane was one that's no longer used, I don't think. But it would set off malignant hyperthermia. Temperature is 106, 108, rigidity, spasticity, tremors, and so on. Well, that intrigued me. There is not only a human model, it was a pig model, and these animals display changes, not the temperature. The temperature rises because of the energy, the heat generated by the breakdown of ATP, of adenosine triphosphate. But it's the tremors and the spasms and the rigidity that intrigued me. And I published the paper, and the day after the paper came out, I get an email from a woman who says, my husband is affected by this. Not much with the malignant hyperthermia, but he has the mutation and he has pain on exercise. So that's intriguing. I actually, before that, I'd gone back to the literature and I found one article of someone looked at people with muscle pain on exercise, 32 subjects, 14 of these subjects had the mutation or a variant. Intriguing to me. So I'm thinking now that there's and not all these people who had exercise-induced pain had the full picture of malignant hyperthermia, thank goodness. So now I've got a study plan to look at how many of these people with the mutation, and there are over 400 mutations known in the ryanodine receptor. How many of these people who have known mutations have exercise pain? There's a population that is intriguing to study.